Good afternoon, everybody. I would like to welcome all of you to the second SR update for this year, which will be done by Dr. Kalani Samarasinghe, who is the Senior Registrar at National Hospital, Colombo. I'm joining from the SLCD office where we have Dr. Chalukya Gunasekara and Dr. Premini Rajendran. Dr. Kalani is going to speak to us today on cutaneous side effects of targeted immune modulators. Over to you, Kalani.
Thank you very much, Madam. Good afternoon, everyone. First of all, I would like to thank Sri Lanka College of Dermatology for giving me this opportunity. And I have selected the topic, cutaneous manifestations of targeted immune modulators, as my SR update. I have selected this topic because with the novel advancement of the clinical medicine, there is increased trend of using targeted immune modulators, not only in dermatology, but also in other fields of medicine. So, as dermatologists, I think it's good to have an updated knowledge regarding the cutaneous side effects of this novel therapeutic agent. Let me start off by giving you a brief overview about the targeted immune modulators. As clinicians, we have been using DMARDs, or the disease-modifying anti-rheumatoid drugs, since years in managing immune as well as inflammatory dermatosis. We all know that even though they work very well on these immune and the inflammatory disorders, they carry a higher risk of side effects due to its non-specific action on the immune system. So, it kills both pathogenic as well as the non-pathogenic cells in the immune system. So, recently, we have been introduced to the concept of targeted immune modulators, where there is more specific killing of the pathogenic cells in the immune system without killing the non-pathogenic cells in the immune system. So, let's see how these targeted immune modulators act on our cellular system. It acts mainly on two pathways. One is extracellular signal transduction pathway, and the other one is intracellular signal transduction pathway. You can see in this picture what is extracellular signal transduction pathway. It mainly consists of the cytokines and growth factors, and also they are soluble as well as membrane-bound receptors. The drugs which specifically made to block this extracellular signal transduction pathway are known as monoclonal antibodies. And then the intracellular signal transduction pathway begins, and it extends from the membrane to the cellular nucleus, ultimately cause gene transcription and protein synthesis and several immune and inflammatory disorders. So, there are another set of intracellular messenger molecules that transmit these cellular signals between these two endpoints. Drugs which are specifically made to block these intracellular signal transduction pathway are known as small molecular agents. As these molecules are small, are having small molecular weight, these drugs can penetrate cellular membrane freely, and thereby they can exert their immune modulatory effects successfully. So, as in a summary, targeted immune modulators act either by interfering with cytokine function, signal transduction or production, or by inhibiting the second signal which required for the T cell activation, or by depleting the B cell. Let's see the classification of the targeted immune modulators. Every day, new targeted immune modulators are being made and introduced to the market. So, it's difficult to remember all these drugs and discuss about all of them. So, in my presentation, I'm touching mainly the targeted immune modulators which are available in Sri Lanka, as well as which have some dermatological point of interest. So, under the targeted immune modulators, first category is the biologic. Under that, I'm discussing about the TNF alpha inhibitors, interleukin 12-23 inhibitors, interleukin 17 inhibitors, interleukin 6 inhibitors, interleukin 23 inhibitors, and the B cell inhibitors. Second type of targeted immune modulators are small molecular agents Under that, the main category is genus kinase inhibitors or the kinase inhibitors. And thirdly, there are another set of targeted immune modulators which specifically made in cancer therapy. Under that, there are two main types. One is the MAPK pathway inhibitors. Under that, BRAF and MEK inhibitors I am going to touch on. And the next one is the immune checkpoint inhibitors. So let's see one by one. Under the biologics, first category is TNF alpha inhibitors. So infliximab is the biologic we have been using for a long time period. It's even in Sri Lanka, it's a chimeric monoclonal antibody which is directed against TNF alpha. This is the chimeric refers to as this drug contains both murine as well as the human component. This is administered via intravenous infusions and approximately every 8 weekly duration. So, as this is a chimeric drug, there is increased risk of developing anti-drug antibody, which leads to development of more side effects with TNF with the infliximab. The main indications are psoriasis, psoriatic arthritis, rheumatoid arthritis, and IBD. Next one is the etanercept. Is a soluble P75 TNF receptor fusion protein. However, this is not much popular in Sri Lanka. Third one is the adalimumab, and it's a fully human monoclonal antibody that is administered subcutaneously. And because it's a fully human drug, there is lower risk of anti-drug antibody formation compared to infliximab. We are using adalimumab for the psoriasis, psoriatic arthritis, and especially for the hidradenitis suppurativa patients. Then next one is the certolizumab. This is important because this is a drug we can use even in pregnancy. Next one is the golimumab. This is more popular among rheumatologists than in the dermatologists. So let's move from the TNF alpha blockers to the interleukin 12-23 blockers. Available drug is the guselkumab, and it's a human IgG monoclonal antibody that binds to the P40 subunit shared by both interleukin 12 and 23. So this drug administered every 12 weekly in subcutaneous route. This is important because this is more patient. This is a patient-friendly drug, as patient needs to come to the hospital in 3 months times, as well as drug is given subcutaneous, so there's no need of admissions to the hospital. So indications are moderate to severe IBD, psoriasis, and the psoriatic arthritis. Next one is the interleukin 17 inhibitors. Available drug is the secukinumab. It's a human IgG monoclonal antibody against interleukin 17, which is administered by monthly subcutaneous injections after several loading doses. Since recently, we have been using secukinumab for our very resistant and recalcitrant cases of both plaque as well as pustular psoriasis, whom already failed most of the available biologics. So actually, this drug works very well on these patients. So next class is the interleukin 23 inhibitors. Under that, available drug is the guselkumab. And next one is the interleukin 6 inhibitors. Tocilizumab is available in Sri Lanka. It is a humanized anti-human interleukin 6 receptor antibody. Main indications are hyper-IgD syndrome, rheumatoid arthritis, and JIA. And recently, tocilizumab is using more and more for severe COVID-19 patients. And next class is the interleukin 1 inhibitor, anakinra, rilonacept, and the canakinumab are available drugs. However, these drugs are not popular or freely available in Sri Lanka. Main indication is the autoinflammatory condition. Next class is the drugs which deplete or inhibit the B cells. Under that, rituximab is the available drug, which is a chimeric IgG monoclonal antibody, which eliminates CD20 positive B cells. And this drug is administered as short series of typically 2 to 4 IV infusions in every 4 to 6 months or at long intervals as needed. The main indications are lymphoproliferative disorders and the rheumatoid arthritis. However, in dermatology, we use this drug for severe recalcitrant cases of bullous dermatosis and as well as for the severe cases of connective tissue disorders. For our patients, even with severe, our patients show very good response to rituximab. So usually they go into remission even with the first cycle of the rituximab treatment, and they usually do not need frequent infusions like 4 to 6 months duration. So let's move from the biologics to the small molecule agents which act on the intracellular signaling pathway. Under that, kinase inhibitors is the first class. So the genus kinase inhibitors are available in Sri Lanka. Those are small molecules that target receptor-mediated signal transduction from cytoplasmic protein, tyrosine kinases, to the cellular nucleus. They are highly targeted molecules, and the advantage over the biologics is these drugs are administered by the oral route. So the available drugs are tofacitinib and the baricitinib. Indications are rheumatoid arthritis, vitiligo, alopecia areata, and psoriatic arthritis. However, these drugs are not freely available in government sector, so our patients can't freely access to these medications. So let's move to the targeted therapy, which is used in cutaneous malignancy. Under that, there are two main categories. One is MAPK pathway inhibitors, and the other one is the immune checkpoint inhibitors. You can see in this picture what is MAPK pathway. The MAPK pathway gets activated when growth factor binds with the tyrosine kinase receptors, and then via chain of intracellular interconnected proteins named RAS, BRAF, MET, and ERK. These signals then transfer to the cellular nucleus, which ultimately results in cellular proliferation, growth, as well as the differentiation. So genetic alterations which occur in this pathway may lead to uncontrolled proliferation of the cells and cause several tumors, especially malignant melanoma. So by blocking this pathway, we can recently targeted therapies have been made, and under that, BRAF inhibitors, the available drugs are vemurafenib and the dabrafenib, and under the MET inhibitor, the available drug is the trametinib. So main indication is the metastatic melanoma. Studies have shown that with the introduction of these MAPK pathway inhibitors, the survival rate of metastatic melanoma patients increased by 50%. So let's see the next class of targeted immune modulators used in the cancer therapy, that is immune checkpoint inhibitors. Immune checkpoints are specifically made to prevent activation of our own immune system. So, but in cancer therapy, these checkpoints are inhibited and thereby activate our own immune system against the tumor cells in a beneficial way. So under that, there are two main categories. One is CTLA-4 inhibitors, or the cytotoxic T lymphocyte associated protein 4 inhibitors. That's the available drug is the ipilimumab. And the next one is the PD-1 inhibitors, or the programmed death receptor 1 inhibitors. The available drugs are the nivolumab or the pembrolizumab. CTLA-4 inhibitor blocks the interaction between CD80-86 with its ligand, so allowing T cell so CD80-86 can bind with CD28 that allowing cytotoxic T cell activation, which can cause cytotoxic T cell response against the tumor cells. Next class is the nivolumab, which inhibits the interaction between the programmed death receptor 1 and its ligand, and thereby it enhances the anti-tumor response. Main indication is the metastatic melanoma. So let's move on to the cutaneous adverse effects of biologics. So first class is the CNS alpha inhibitors, and out of all the biologics, CNS alpha inhibitors are the biologics which manifest highest number of cutaneous side effects. However, it is a drug we have been using since decades, and therefore available data also more with CNS alpha compared to the other drug categories. You can see in this table type of cutaneous adverse reactions as well as their incidence and their strength of association with CNS alpha inhibitors. Most of these data are collected from the patients whom treated with TNF alpha, patients with IBD whom treated with TNF alpha. You can see in this table, out of all the reactions, infusion reactions and injection site reactions are the commonest, and they have very strong associations. So let's see what is the infusion reaction. There are two types of infusion reactions. First one is the acute infusion reaction, and the second one is the delayed infusion reaction. Acute infusion reaction usually occurs within the first 24 hours of treatment, and they rarely evolve into anaphylaxis state. The incidence about 3%, and due to the acute infusion reaction, incomplete infusion documented about 0.3% of patients. Those are not purely immunogenic, and they related to the administration rate. Second one is the delayed site infusion reaction. Onset usually between the 24 hours to the 14 days after the infusion, and they are not directly linked to the type 4 hypersensitive reaction. Those delayed infusion reactions are mainly due to the formation of anti-drug antibodies against infliximab. So it's mainly type 3 type or the serum sickness-like reaction. Studies have shown that this risk increases 2 to 3-fold with the longer time interval between the infusion. So let's see what's the management of infusion reaction. We can actually supportive measures like decrease the infusion rate, antihistamines, NSAIDs, and we can use steroids also. Prophylaxis protocols have been proposed to prevent the recurrence of infusion reaction. However, meta-analysis failed to show any reduction of acute infusion reaction with pre-treatment medication. Only in severe cases, we have to think about an alternative treatment. Next one is the injection site reaction. They are often mild and self-limited, usually occurs about 1 to 24 hours after the injection and peaks at about 48 hours the infection. And there are recall reactions also mentioned in the literature. Out of all the injection site reactions, 40% of the injection site reactions are immune mediated. That means either type 1 or type 3 hypersensitive reaction, which are due to either IgE or IgG. Rest of the injection site reactions are mainly due to the irritant effect. So reactions which occur due to the irritant effect may reduce with the subsequent injection. Incidence is higher with the etanercept and least with the infliximab. Let's see the management. Mainly the supportive care, rarely require treatment, as well as we can use cold compression and painkillers. Also, we can keep the biologic rested at room temperature 30 to 45 minutes before the injection. And also, auto-injectors are preferred than manually filled syringe in preventing the injection site reaction, because auto-injectors always penetrate the skin at the same level, not like pre-filled syringe, not like manually filled syringe. And even though these injection site reactions are very harmless, they do not cause any reduction of the drug efficacy or the amount of drug absorption. Studies have shown that identifying the type 1 IgE mediated hypersensitivity reaction is important, because they can predict future development of anaphylaxis with further injection. This correlation of type 1 IgE mediated hypersensitivity reaction and future development of anaphylaxis showed in this article. Next, cutaneous adverse effects of TNF alpha are eczematous reactions. They are fairly common and incidence about 5 to 20% of patients with IBD. And risk factors are personal or family history of atopic and on long-term treatment of anti-TNF medication. Proposed pathogenesis is by using TNF alpha blockers, there is a decrease of the expression of interleukin 17 related cytokines. So there is reciprocal regulation between the T helper 2 and T helper 17 cytokines. So there is apparent increase of the T helper 2 response, which ultimately leads to eczematous skin lesion forming. Management, similar to the primary eczema management, and only for the recalcitrant cases, we have to switch to another biologic. Next, the cutaneous infection by both bacterial, viral, as well as the fungal infections are documented in the literature. Out of all the bacterial infections, erysipelas is the commonest. And even though we are very cautious about the reactivation of pulmonary TB following anti-TNF alpha medication, extrapulmonary TB, including the cutaneous TB as well as the atypical mycobacterial infections, are very rare in patients treated with TNF alpha inhibitor. So in management, we have to recognize these cases early and start appropriate treatment promptly. As well as we can offer varicella vaccination for the high-risk patients, and for HSV reactivation, there's no need to stop the medication. We can continue the drug with acyclovir prophylaxis. And for the cutaneous mycobacterial infection, discontinuation of therapy is recommended during antimycobacterial treatment only. It's only for about 2 to 6 months duration. No need to complete stop the drug. Next one is the psoriasis reaction. We use TNF alpha for the psoriasis, so this is a paradoxical adverse effect. De novo psoriasis as well as exacerbation of pre-existing psoriasis reported with TNF alpha medication. De novo psoriasis mainly with infliximab and the adalimumab, and exacerbation of pre-existing psoriasis mainly documented with etanercept. And more than the pure psoriasis, overlap between the psoriasis and psoriasiform dermatitis has been reported more. And average time of onset about 3 months to 18 months duration. So clinical features similar to primary psoriasis. However, interestingly, these patients have more pustular lesions on the palms and soles compared to the primary psoriasis patients. It's about 40%, but in primary psoriasis patients, it's about 1%. And mechanism you can see in this picture. By using anti-TNF alpha medication, there is increased production of plasmacytoid dendritic cells, which ultimately leads to increased interferon and several chemokines, which leads to psoriasiform lesion formation. So management, similar to primary psoriasis management, for extensive disease, we can combine with MTX, cyclosporine, acitretin, or phototherapy. For recalcitrant severe disease, only we have to switch to another biologic like ustekinumab or secukinumab. Next important side effect is lupus-like syndrome. This is very rare, but the incidence about 0.19 to 5.7 for infliximab. It develops usually after 3 drug doses and resolves after a median of 7 weeks after stopping the biologic. The diagnosis is made by the temporal relationship between the symptoms and the start of the biologic, and resolution after stopping the drug, and by the presence of autoantibodies. Regarding the autoantibody induction following TNF alpha medication, it's fairly common. And ANA, it's about 20 to 60%. Anti-dsDNA, it's about 15 to 20%. And antihistone, it's about 20%. However, even though it commonly induces autoantibodies, clinical lupus is very, very rare. So, routine monitoring of these autoantibodies are not recommended. And compared to the other drug-induced lupus, these patients mostly show anti-dsDNA, ANA, and more hypercomplementemia, but less antihistone antibodies. Management, usually we have to withdraw the drug only during the acute period, but then we can cautiously reintroduce the drug. These are some evidence of drug-induced, TNF alpha-induced lupus. Next adverse effects is the vascular lesions. There are several types mentioned in the literature. Leukocytoclastic vasculitis, erythema elevatum diutrinum, and the urticarial vasculitis. It's a very rare side effect, reported about 0.2 to 0.5% of IBD patients who are treated with TNF alpha inhibitors, and more cases with etanercept than infliximab. This is interesting because most of other side effects are more with infliximab, but this is more with etanercept. And onset about 9 months after initiation of treatment. And even though they get vasculitis, visceral cutaneous vasculitis, visceral involvement is very rare. If so, it is more with renal and the peripheral nervous system. Presentation may be varied from the palpable purpura, subcutaneous nodules to the chilblain-like lesion. And in management, usually we have to withdraw the drug in the acute state and usually resolves after the withdrawal. And studies have shown that rechallenge with the same TNF-alpha blocker leads to relapse in 67% of cases. And with a different TNF-alpha blocker, it's about 33% of cases. And we can combine with other systemic immunosuppressants. These are some evidence for the drug-induced cutaneous vasculitis. Next side effect, cutaneous adverse effect, is the lichenoid reaction. This is also rare, but three main types are described in the literature. One is typical LP lichen planus-like lesion, and the second one is non-specific macular and papular lesions. Third one is these lesions have psoriasis clinically, but they show lichenoid histological characteristics. And other than about three types, pigmented lichenoid drug eruptions and lichen planopilaris also mentioned in the literature. In management, for most of these cases, there is no need to stop the medication and we can continue the drug with other supportive treatment for the cutaneous side effects. So one case report, the Bechet patient who has received adalimumab and later developed lichen planopilaris following treatment. Next side effect is also important. It is granulomatous reaction. We all know that we use TNF-alpha for the granulomatous dermatosis like diseases like IBD as well as sarcoidosis. So this is a paradoxical reaction. Examples are granuloma annularis, sarcoidosis, and interstitial granulomatous dermatitis-like reaction. In management, we have to rule out all infectious granulomas, and then we can combine with topical as well as systemic steroids. However, stopping the drug is not recommended in all cases, but in severe sarcoidosis-like cases, they had to withdraw the medication and go for an alternative. Next side effect is alopecia areata or the vitiligo. This is also very rare. Onset typically 6 weeks after starting the treatment and reported up to 8 months of treatment. Mechanism is not known fully, but proposed mechanism is due to TNF-alpha inhibitors, there is inhibition of regulatory T cells which are responsible to maintain immunological tolerance and thereby which prevents development of autoimmunity. So by TNF-alpha blockers, there can be development of autoimmunological disorders. Management mainly supportive. We have to withhold medication only in severe cases. The case report which illustrates adalimumab-induced alopecia areata. You can see in this picture how severe it is and how distressing it is to the patient. Next side effect is the dermatomyositis or the polymyositis developing following TNF-alpha medication. And this is very rare and it's a paradoxical autoimmune process. Incidence less than 1% of reported cases of anti-TNF-alpha induced autoimmune phenomenon. And the onset usually ranges from 2 months to 24 months after initiation of therapy. And interestingly, this is also more commonly associated with etanercept than the infliximab. Clinical features and the investigations are similar to primary dermatomyositis. And in management, in this case, as is severe side effect, we have to withhold the drug and then later decide on an alternative biologic. These are some evidence of development of classic dermatomyositis following initiation of anti-TNF-alpha medication. Next side effect is the cutaneous malignancy, which are developing following TNF-alpha inhibitors. These are relatively rare, but this is more for the non-melanoma skin cancer. And the risk increase for the BCCs more than the SCCs. And however, studies have failed to show any increased risk for other types of skin cancer development following TNF-alpha medications, including the mycosis fungoides. And other risk factors also may be contributing to development of these cutaneous malignancies, like primary skin lesion or the primary immune disease. Like example is anyway, rheumatoid arthritis patients are at increased risk of a cancer. And the other thing is treatment with photosensitizing medications and immunosuppressants like thiopurine or the poor treatment. And thirdly, following sun exposure and the skin phototype. And in management, we have to regularly monitor these patients for these side effects, and we have to take action early when they develop. And next one is the hidradenitis suppurativa. We use TNF-alpha for hidradenitis suppurativa. However, paradoxically, there are cases of development of hidradenitis suppurativa in patients whom treated with TNF-alpha inhibitors. So it's an unusual side effect, onset about median of 12 months after starting the medication. And this is important to know regarding this side effect, because majority of these patients present in early stage 3. That means in the severe stage of the disease. And pathophysiology is not fully known. Proposed one is could be due to the dysregulation of the cytokine dysregulation and imbalance of pro-inflammatory cytokines due to TNF-alpha medication. And for the mild disease, actually, we can continue the TNF-alpha medication, but for the severe disease, we have to switch to another biologic. And these are some evidence. And let's move from TNF-alpha to the interleukin 12-23 inhibitors or the cutaneous adverse effects of ustekinumab. It is compared to the TNF-alpha, it's very rare, and incidence about less than 1%. And also, fortunately, paradoxical reactions not reported with ustekinumab treatment as in TNF-alpha. Out of all the side effects, injection site reactions are the commonest, and other than that, cutaneous infections, urticarial reactions, and bullous skin eruptions like lesions also are mentioned in the literature. And this is one case report which illustrates ustekinumab induced subacute cutaneous lupus. And these are some case reports, ustekinumab causing fixed drug eruption. And next side effect is leukocytoclastic vasculitis developing following ustekinumab treatment. In the, for these patients, actually we have to withhold the drug for a short period, and in most of these cases, they have reintroduced the drug. Next, let's move on to the cutaneous adverse effects of interleukin 17 inhibitors or the secukinumab. Out of all the cutaneous adverse effects, mucocutaneous candidiasis is the commonest adverse effect. And the proposed pathogenesis is, we all know that interleukin 17 response has a critical role in immune defense against the candida infection. So by blocking the interleukin 17 pathway, that leads to development of mucocutaneous candidiasis. Other than that, injection site reactions they have mentioned, and also the cutaneous vasculitis. Other than that, another side effect of secukinumab is bullous or acral eruption and dyshydrotic eczema. That is mainly due to, by blocking of the T helper 17 cytokines, there is apparent increase of or the activation of the T helper 2 mediated pathways and the increased T helper 2 related cytokines, which ultimately leads to eczematous or dyshydrotic lesion. So let's see what are the cutaneous adverse effects of rituximab or the B cell inhibitor. Those are very rare. Infusion reactions are mentioned, and those are the most commonly reported adverse effects. And many develop within the first 24 hours of first infusion of the rituximab, and those are dose dependent, and frequency of reactions decrease with subsequent infusion. However, life-threatening anaphylaxis are very rare. So for the mild reactions, we can temporarily interrupt the drug or slow in the infusion rate, and we can continue the treatment. And only for the severe reactions like anaphylaxis-like reactions, we have to discontinue the therapy. Next side effect is leukocytoclastic vasculitis, and onset range from 2 days after the first infusion to the several months, and pathophysiology is controversial. However, anti-rituximab antibody complex deposition on the vessel wall, which cause cytokine release and causing vasculitis, is a one proposed mechanism. These are some evidence for the rituximab-induced vasculitis. And other than that, there are some less frequently reported adverse effects. So let's see what are the cutaneous adverse effects of interleukin-1 antagonists like anakinra. Injection site reactions are the commonest adverse effects they have mentioned, and it occurs about 50% of patients, and usually self-limiting, and usually may not need any treatment withdrawal. Let's see what are the adverse effects of tocilizumab. Cutaneous adverse effects are rare with tocilizumab. However, they mention cutaneous infection and the cutaneous vasculitis with tocilizumab treatment. Interestingly, there are several case reports of cutaneous sarcoidosis development following tocilizumab treatment, and also these tocilizumab associated with several severe cutaneous adverse reactions like breast syndrome. There are many case reports reported breast syndrome following tocilizumab treatment. So let's move from the biologics to the cutaneous side effects of JAK inhibitors or the Janus kinase inhibitors. Under that, the drug I'm talking about, tofacitinib. The incidence of dermatological reactions are not known with the tofacitinib. However, the cutaneous side effects mentioned in the literature are the cutaneous infection, urticaria reaction, generalized pruritus, and also the breast syndrome. And they also mention non-melanoma skin cancer developing following tocilizumab treatment. That is mainly due to by blocking the JAK-STAT pathway, there is down regulation of interferon and some pro-inflammatory cytokines, which paradoxically can cause tumor formation by downstreaming the cytotoxic T cell signaling. So next adverse effect of tofacitinib is the vitiligo. We all know that oral as well as the topical tofacitinib currently using as one of the promising therapeutic modalities for vitiligo. However, with tofacitinib treatment, there are paradoxical vitiligo lesion development mentioned in the literature. So, first mechanism is tofacitinib mainly blocks the JAK3 and 1 dependent STAT activation. So, it can lead to paradoxical upregulation of the JAK2 pathway, which ultimately leads to upregulation of interferon gamma and several chemokines, which leads to vitiligo lesion formation. These are some evidence. Then let's move to the cutaneous adverse effects of targeted therapy in cancer treatment, and it's mainly for the first one I'm touching is the BRAF inhibitor. Under that, vemurafenib and the dabrafenib. Those are relatively common and usually occurs in the early treatment, like weeks after initiation of the treatment. And this is mainly due to BRAF represent a downstream mediator of the epidermal growth factor signaling, which is critical regulator of epidermal homeostasis. So, by blocking this MAPK pathway, there is disruption of this epidermal homeostasis, which leads to multiple cutaneous manifestations. And also, BRAF inhibitors can promote paradoxical activation of MAPK pathway in cells that do not carry BRAF mutation, which leads to keratinocyte hyperproliferation. So, by using the MEK inhibitor concomitantly, we can actually prevent this paradoxical activation, and thereby we can significantly reduce the amount of cutaneous adverse effects. So, out of the cutaneous manifestations of BRAF inhibitors, skin rashes are the commonest, and it is more with vemurafenib. It's about 64 to 70% of the patients who receive vemurafenib, and usually occurs 2 weeks after initiation of the treatment. And for these side effects, actually, there's no need to stop the medication. We can actually continue. That is known as treating through concept. And also other cutaneous adverse effects mentioned are the acneiform eruptions, photosensitivity, and also keratosis pilaris-like lesions. They have also mentioned seborrheic dermatitis-like eruptions following drug inhibitors. And this is important side effect of drug inhibitors, that is hyperkeratosis of hands and feet. And this is important because so this associated with about developed in about 10% of patients who is on vemurafenib treatment, and this is a very debilitating side effect. So sometimes we have to withhold the drug, or we have to give treatment holidays for these patients, as this is a very debilitating side effect. Next side effect is the epidermal neoplasms developing following drug inhibitors. Those are mainly SCCs, keratoacanthomas, and verrucous keratosis. And usual median time of onset about 8 weeks after initiation of the treatment. And they sometimes appear as eruptive fashion also. Mechanism mainly by blocking the BRAF pathway and the MAPK pathway by blocking the BRAF. There can be paradoxical MAPK pathway activation where there is already sun-damaged cells with RAS mutation. So, because of that, by introducing the BRAF inhibitor, sometimes there can be eruptive SCCs and keratoacanthomas developing even within weeks after starting the treatment. Management similar to other cases of cutaneous carcinoma management. In these cases also, we can continue the drug without disruption the medication to the without disrupting the medication. And other side effects reported with drug inhibitors are the panniculitis, as well as they have mentioned melanocytic lesions with drug inhibitors. There can be eruptive nevi, or there can be dynamic changes in cystine nevi. However, development of second primary melanoma is very rare occurrence, even though there are some non-melanoma skin cancer development. This is the one case report which illustrates panniculitis in patients treating with BRAF inhibitors. So other rare manifestations are non-scarring alopecia, facial erythema, to eruptive media or epidermoid cyst formation. Next one is the cutaneous effects of MEK inhibitors. Under that, trametinib is the available drug. So it reported side effects are morbilliform eruptions, papulopustular lesions to the paronychia or trichomegaly. And next, let's see the cutaneous adverse effects of CTLA4 inhibitors, or the immune checkpoint inhibitors. Under that, available drug is the ipilimumab. And autoimmune dermatoses are most frequently observed with these immune checkpoint inhibitors, and it's about 40% of patients. And usually they have an early onset, about 3 to 6 weeks after initiation of the treatment. And reported cutaneous adverse effects are morbilliform skin eruptions, lichenoid eruptions, and vitiligo-like lesions. So next class of immune checkpoint inhibitors are the PD-1 blockers or the programmed death receptor blockers like nivolumab. It's also common and incidence about 40% of patients. It ranges from the morbilliform eruptions, lichenoid eruptions, to the sarcoid-like granulomas or epidermal neoplasms. Recently, there are many case reports of psoriasis development following nivolumab treatment. I have come to the end of my presentation. I'm very sorry that most of you might overwhelm with the cutaneous side effects of these targeted immune modulators, which I have already mentioned. So quickly, I like to point down some take-home messages. Those are cutaneous adverse effects are more frequently reported with TNF-alpha blockers more than any other biologics or the targeted immune modulators. And out of all the TNF-alpha, it's more with infliximab than other types of TNF-alpha drugs. And it is mainly due to anti-drug antibody formation. And interestingly, paradoxical worsening of the inflammatory dermatosis also mentioned with the use of these biologics. And most cutaneous side effects can be managed without withdrawing the culprit. That's a good point because that's known as treating proof concept. We can continue the drug with supportive measures to the cutaneous side effects. And next one, and also ustekinumab carries the least risk of cutaneous adverse effects. So we can use ustekinumab as an alternative for the paradoxical reactions which develop following TNF-alpha inhibitors. And also severe cutaneous adverse reactions like breast syndrome are reported with rituximab, tocilizumab, and the Janus kinase inhibitors. Thank you for your kind attention.